Trying to conceive and feeling overwhelmed and confused with unhelpful information and advice? This podcast is for you. Welcome to Don't Tell Me to Relax. I'm your host, Hannah Pern, a fertility acupuncturist and passionate advocate for better fertility education and support. Our aim is to empower you with information to support your fertility journey and provide a community for connection with people who get where you're at. If you'd like to join us or work with us in clinic in London or across the UK, all the information is in the show notes at the end. Hello, James. Thank you for joining us today. Before we crack on, it would be great if you could introduce yourselves and tell us about your work.
It's a pleasure to be here. So thank you for the invite. I'm James Nicopoullos. I'm the clinical director and person responsible at the Leicester Fertility Clinic. Person responsible sounds like a wonderful title, but it just means that I get the blame for stuff when things go wrong. I'm the person that is responsible for making me follow all the important regulation. There's one in every clinic. I've been at Leicester for 15 years, clinical director for about 6, and incredibly proud of our 22,000 odd babies that we're up to now over the years.
Wow, is that the number that it is?
Yeah, over 22,000. Brilliant.
Wow, fantastic. Fantastic. So today we are going to be talking all about IVF add-ons because it's a topic that causes a lot of confusion, a lot of stress, a lot of anxiety. There's all kinds of weird and wonderful information out there about it. So I thought that you would be well placed to tell us about IVF add-ons. So can you tell us a little bit about when we talk about IVF add-ons, what do we mean?
It is a really important area. So I think it's a really good thing to be talking about. In essence, an IVF cycle has got certain absolutes that we know you need. You need to be stimulated, you need eggs, you need sperm, they need to be fertilized. Embryos need to grow, we need to stick them back in or freeze them. Those are the core parts of any IVF cycle. In essence, an add-on or an adjuvant, depending on what you want to call it, is potential. It's like an optional, non-essential extra that you may or may not need as part of your cycle. And that will be very much based on your individual circumstances, your individual clinical picture. And it's become a little bit controversial because a lot of these add-ons have a mixed evidence base, and we always want to do whatever we can, if we're doing the right thing, with as best level of evidence as we have. So we want to make sure that if people are being offered these add-ons, they are the right thing to do, especially because in many scenarios you're paying for them. So it's important that people aren't being asked to pay for stuff they don't need.
And how long have IVF add-ons been around? Like, when did they come into fashion?
Forever.
Okay.
But the term add-on has really been a sexy term, for one of the better phrases, for 4 or 5 years. And in many ways, you could argue that something like ICSI that we always do now when we need to for poor sperm or certain scenarios, you could even argue that initially was an add-on, because when IVF started in the 70s, we couldn't do ICSI, but suddenly come 1992, we could, and it was an add-on. We don't see it as an add-on anymore. It's an essential part of treatment. But they've always been there, and sometimes they're just new techniques that haven't quite been proven yet.
And am I right in saying that add-ons they very much sit in the private world of fertility, or are add-ons available, say, for example, if you had a round of treatment on the NHS, would you be offered add-ons as part of that?
I think to a certain, this is a really, really grey area, partly because it's not always as clear-cut as an NHS treatment cycle, or as, it is. Let me go back a step. There is treatment in an NHS clinic, and even within an NHS clinic, you could be having an NHS cycle that's being funded for by the NHS, or you can have a treatment in an NHS clinic that you're paying for yourself. Frustratingly, the same thing should happen in that clinic, whether you're paying for it yourself or the NHS. Is something's either right or wrong. But yes, in some scenarios, the NHS package will only include certain things, and thereafter, if your doctor genuinely thinks you need an add-on within the NHS cycle, you may or may not be able to pay for it yourself. So not always is the case, but yes, it's predominantly private.
Yeah. And so tell us, what are, in your clinic, so at the Lister, what are the main add-ons that you use? Do you use all of them, or do you have certain ones that are more popular than others?
I think that I may be preempting a question that's coming up, so I'll apologise in advance. I think that IVF is I hate the term industry, but as an industry, it's really, really important that we all do the right thing. And I'm going to be slightly cynical and say perhaps over the years, some clinics have pushed certain treatments, call them add-ons, too quickly, that they shouldn't, too expensive treatments, lack of evidence base. So it's become a really controversial area. And the HFEA getting involved in this about 5 or 6 years ago, as much as regulators sometimes think they're all in and we all get a bit cheesed off, it was a really good thing. Because what it gave us is it gave us some backing. So the patient came to see me, and patients are often, really vulnerable, often really desperate because we know what they're trying to get. They will try anything. But it's important they don't try anything if it's to their detriment. So this template that the HFEA gave us, and we'll come to the details in a minute maybe, allowed me, when the patient came to say, I've been recommended this on forum or a friend or whatever, it gave me a bit of backing because it wasn't just me saying, you don't need this, it's not going to work, it's not going to improve outcome. I also had this great document from the HFEA to say, look, it's bright neon red. They're saying you shouldn't have it. So I think the HFEA stepping in and giving us a little bit of a backbone and a structure around add-ons is really, really useful. Now, I don't always agree with them, and we'll come on to that in a minute. But it really, I think it's great that that's there now, this tracking light system that we'll talk about. We don't, to answer your question eventually, we don't use all of them. We use the ones that we think are worth using. And we spend a lot of time because there's an evidence base that we need to use. And we also need to make sure that something that you add works for you in your clinic. So I've got our 22-page patient information leaflet in front of me on fertility adjuvants. And what we've done is basically use the HFEA's information so that patients know the pros, the cons, the risks of all the adjuvants, and also what our opinion is on them and how it works for us. So there's certain things that are on that list, like assisted hatching, that over the years has been used, but we never use it because for us, it doesn't work. There isn't an evidence base. Assisted hatching is when you just laser or chemically create a hole in the shell of the embryo just to help it hatch out and implant. But an embryo is going to do that on its own if it's up to the job. There are other things like intrauterine culture, which is basically when you inject some fluid into the uterus before transfer. Can you improve the environment? Again, that's there isn't a great evidence base either way for that. It's not something that we've used. There's 2 or 3 different sperm selection techniques, like IMSI, when you just use a uber high magnification microscope to uber select the sperm, or PIXI, when you use a special membrane to try and select the best sperm. There's no point having all of those, so we just use IMSI on occasion for the right group of people. So the answer is we use most, or most are available for the right group of patients.
So is that embryo glue you were talking about? Or is that something different?
No, so the intrauterine culture is something you inject into the uterus that has been potentially postulated to improve outcome. We don't use that. So embryo glue, I've always said that I'd love to employ the bloke that came up with that name, embryo glue, because it's just marketing genius, isn't it? Because it just makes you want to use it.
Yeah.
And it's been a great topic over the years in that it's been up and down in terms of the evidence base. And what embryo glue is, we grow embryos in culture fluid, and then just before transfer, you pick the right embryo and put it back in. Embryo glue is a fluid that you put embryos in for an hour or so before you do a transfer that seems to provide some nutrients that may improve the outcome. We tried it a few years ago for a few months, didn't see an improvement in outcome, so haven't used it. Interestingly, because there is some nice evidence for glue. It's one of the yellow on the traffic light system. So not absolutely definitely improves outcome, but could do. So again, we did it for 3 months late last year as another test. And this goes back to what I said about having to try these things in your own clinic, because we were so confident that what we did already worked. We never used it, but we did see a small benefit. So we have again started using glue moving forward. But this is a really good example where I struggle sometimes with some of the terms that are used and the fact that there are add-ons, because for me, if embryo glue improves outcome, it shouldn't be add-on, it should be used for everybody. So that's where I really struggle. You shouldn't be charging somebody 300 quid for something extra if you think it works for everybody. So we've now making a decision, for example, in all our frozen transfers, everybody gets embryo glue, because if we think it's worth it, everybody should get it. It shouldn't be selective for some people. So now everybody gets embryo glue, for example.
Right. Okay, so everyone gets it in a frozen transfer?
Yeah. We're trying to work out the mechanism of doing it in a fresh, because we like to choose the embryo as late as we can to make sure we're picking the right one. So we're looking at how to do it in all our fresh as well. But we're using it for all frozen embryo transfers initially, and then we're probably moving on to fresh at some point.
So I guess that is now not going to be an add-on. That is just going to be part of the package.
For us, yeah, and it's a little bit like time-lapse embryology. And we all got very, very excited about time-lapse and videoing these embryos. I'm still of the opinion that a human with 20 years of experience is going to be better at selecting an embryo than a mathematical algorithm most of the time. But it was useful to have that data. But actually now it's one of the black ones on the HFEA traffic light system, which means that it doesn't improve the outcome. But what it does do is it provides this lovely enclosed incubator. You never have to take the embryos in and out, and you can just video and monitor them. So we have now got time-lapse embryoscopes for everybody. So again, for me, I don't understand where clinics are charging £700 to use a time-lapse incubator. Either you think that's the best incubator and everybody should have them, or you don't think it improves and nobody should have them. It shouldn't be a selective thing. So that's another scenario where, although it's not add-on that may improve the outcome because you can video it and calculate timings, but it's a nice incubator. So it should be used for everybody.
So I guess that comes down to different labs and the quality of different labs.
Yeah, to a certain extent. Some labs may be really happy with what they do already and don't want to rock the boat, and I understand that. But it's about getting the right balance and not adding costs when you don't need it.
So can you tell us a little bit about the traffic light system that the HFE have got? Because it is a bit like mind-bending.
It is. It used to be really easy because in my neck of the woods, a traffic light's got 3 colours.
Yeah.
It used to be red, as in don't use it, not safe or don't improve outcome. Amber, not quite sure, but it's probably okay. And green, go for it. What they've now done is they've still got the green, which is and almost nothing is green, and we can come back to that. Yellow, some evidence of benefit, so could use it. And now they've subdivided the rest, and it all used to be together. So what they've got is black, that there is evidence, and the evidence suggests no difference. There is grey, which is we haven't got enough evidence to be able to say either way. And there's red, which is saying not sure about the safety or the benefit, we don't think you should use it. So, hopefully that makes a bit more sense. But it's a little bit of a making your head explode slightly. But it's trying to tease out the differences between that red, because lots of things were red before. Not all of them were absolutely don't use them. Some of them we're just not quite sure.
There's also quite a lot of procedures that aren't actually listed on there, I've realised.
Yeah, and there's some that have been taken out. Something like calcium ionophore, which is the chemical we use to try and help fertilization when there's problems, because we know there's only a small subgroup of people that should get that, so we should only be using it for them. There's things like sperm DNA testing. And I did all my research. Although I'm a gynecologist, I did all my research in fertility with Jonathan Ramsey, not all, but most of it. That's what my thesis was in. And again, that's not on there as an add-on yet. So there are other tests and things that we do that aren't quite there yet.
And why isn't DNA? Because DNA comes up a lot.
Yeah.
And people talk about it a lot. And so why is it not on? Why is it it's on there, but it's not on there? So they say what it is.
Yeah.
But then they don't give any kind of evidence about whether it should be done or not. So again, it kind of leaves people really confused and sort of unsure about whether or not they should test.
Yeah, I don't know why, because they've given some blurb about it, but they haven't categorized it, and I'm not quite sure why. There was a 100-page document that backs this up, and out of curiosity, I'll go away and have another little look now. But I think part of the problem is that there's so many different sperm DNA tests that they probably just didn't want to come down generically and say yes, no, because there's variations between the different tests.
And And am I right in thinking as well that there is, it takes a long time to get enough evidence to really robustly say this absolutely works. So that there could be tests that we're talking about that in the future they might go, absolutely, this is definitely a thing. It's just that at this point in time we don't have enough evidence.
Absolutely, and that's what the grey is. That grey area is we haven't got enough evidence. And reproductive immunology is a great example. It's red. It's red for a reason. But if you imagine, if you've got somebody in front of you who's had 4 miscarriages or 4 IVF failures, and somebody says, "I potentially got this wonder drug. I want to put you in a trial. You might get this wonder drug, or you might get placebo." They're going to tell that person where to go because they're so desperate. So it's very hard to recruit enough people into a proper trial, which is why we get ourselves into these sort of tangles. And reproductive immunology is a really good example. As red, or for most of it's red, and we'll come back to that in a minute. It absolutely shouldn't be something that you do first line, second line, third line. Frustratingly, there is maybe 1 or 2 clinics that you walk in the door, and because of that level, perhaps the desperation or vulnerability, you're possibly 5 figures down financially before you started the test that most people say you don't need. And that's one of the stimuluses for the HFEA traffic light system. But you've also got to be pragmatic. If you are sitting in front of somebody who's had those 4 miscarriages or those 4 IVF failures with nice embryos, because if they're not nice embryos, we know what the problem is. And you've done, you've checked that there's no polyps and fibroids, you've checked the genetics, you've done X, Y, and Z that have got a good evidence base. At that point, for me personally, I think you have that conversation. You say, look, there is this test. It's going to cost you £500 or £600. The evidence base is great. I haven't got any other evidence-based ideas. And we have that conversation together. Personally, I don't think it's unreasonable only at that point to be talking about these sorts of things, if that makes sense.
Yeah. So it's kind of further, because I always think of it as like a bit like a funnel.
Yeah,
and,
perfect.
As people go through the funnel, they might conceive naturally, they don't conceive naturally, they move to IVF. And, those people who, if there's no logical reason why this implantation failure is happening or miscarriage is happening, they kind of move into that very small number of people who then seem to do the intralipids or the steroids and go on to have a successful pregnancy. And it's not always, but it's something that we see a lot.
Yeah, and it should just be those, though. And I think that's where the problem arises, when people who don't need it. And I also worry that sometimes people are pushed down rabbit holes, if that's the right phrase, that they shouldn't go down. If you've got terrible embryos, you don't need immune testing. You know what the problem is. Sometimes people focus or get themselves really stressed out about one particular area that probably isn't an issue, be it stress, and yes, it's important not to be stressed, but it's also important to make sure people aren't stressed about being stressed, because it could make a difference, but it's probably not going to be the key. Nutrition is important, but your vitamin D levels going to be the absolute reason? Probably not. It's important to fix them. It's about just having the whole picture together.
Yeah. And so the other one that's red is the PGTA testing. So again, why is that red? Because that seems to be great.
Yes. So one thing about the new traffic light system is that before it just looked at the chance of improving the baby rate, and it only looked where there was evidence there. What they've now done is complicated it in a way, so given evidence space for different scenarios. And also, if you look at PGT, on the front page of PGT, it's red. If you click on PGT and go into the details, it's red, it's green, it's grey. So frustratingly, they've given a slightly skewed opinion because there's only 2 things that are green in the whole of that traffic light system. And one of it is something on PGTA. So it's not as simple as they made out. So we all thought 15, 20 years ago that genetic testing of embryos would revolutionize IVF. It hasn't, because testing them doesn't change them. If you've got a genetically normal embryo, you're going to get pregnant and have a baby. if you've got an abnormal embryo, your body's quality control mechanism will sort it out. Or second level of quality control, miscarriage, as horrible as it is. So the endpoint baby rate isn't changed. So it's important people know that at the start. But for a certain subgroup of people, the information that you'll get if you've had a recurrent miscarriage to minimize that risk of miscarriage is invaluable. So it is green for minimizing miscarriage in certain circumstances. The time that you lose by miscarrying is invaluable to many people. And again, there is a bizarre part of the information, if you read it in detail, that suggests the opposite with genetic testing in the HFEA traffic light system. And it doesn't make any sense. Yes, there are the potential negatives in that you have to freeze the embryos. We know frozen embryos work as well as fresh, but maybe 1 or 2% don't survive. We know there's a tiny risk of damaging the embryos, less than 1%. So you have to have that conversation. So for some people, they're going to say, it's not for me. For other people who've been through miscarriage or terminations, it might be the right thing. So it's about individualizing it. And what I often quite like doing is saying, look, we're slightly on the fence, so let's put an embryo in. If you have extra embryos to freeze and you're freezing them anyway, let's test them. Because what I hate is when people have 4 embryos frozen and they come back and use them and they put themselves through physically, emotionally, financially, treatment cycles. If they'd known those embryos that were frozen were normal, they'd use them. If they knew they were abnormal, they wouldn't have to. So I think it's not the panacea. It's not for everybody, but I do think for some people it may be the right thing to do. That makes sense.
It does, yeah. And do you think that that coding will change, or do you think it's going to stay like that? Because is it the risk to the embryos that it's the fact that it doesn't improve your chances? Is that why it's staying as a red?
It's never gonna. But it should, for me, be black. It should be black in that it doesn't make the success rate worse. I'll be honest with you. It also, reading the scientific background of the discussions that came up with these, I do think to a certain extent, and nobody will like me for saying this, I think people who were involved in the decision making, I think went into with slightly preconceived ideas as to where they wanted. They had their opinions about certain tests. Endometrial receptivity, as an example, it's red. So basically where there is a small subgroup of women where it may be that when their lining is ready for an embryo, it might be shifted. So we might be putting embryos that are slightly undercooked or slightly overcooked linings. And we can test that and then shift when we're putting the embryos in. It's red. If I read the background evidence that they base their red summary on, for me, the evidence base for ERA testing is just as good as other things that they've made amber. But my personal opinion is there's a little bit of preconception going in there. So I think these things may change. And I know from our point of view, again, we only do ERA when we're running out of more evidence-based ideas, but our in-house data that we've presented at conferences and that we're going to publish has shown a benefit for endometrial receptivity testing. So I think these things will change with time as hopefully more and more evidence comes out. And some things might go from amber to red. Some things might go the other way. So we just kind of have to watch this space. And I think the key is talking to somebody sensible and getting the pros and cons of everything and making empowering people to have as much information as they can.
And just talking about ERA or the ERA, I noticed that the Emma and the Alice isn't on the list either.
No, it's not. I think that endometrial microbiome is a hugely sexy topic at the moment. I think it's important. I worry that it's being pushed a little bit by the wrong people. And again, suggesting that their microbiome is the main reason why they're not getting pregnant is absolutely an important factor. And we should be looking at it. But I worry that it's being given slightly too much emphasis, perhaps. But yeah, equally, we've got some data, and we use the Emma and the Alice often as part of the trio of testing you do for linings, and we are treating, we are seeing some benefit. And sometimes we do the Emma and the Alice alone, because obviously if somebody's getting pregnant, then the receptivity is fine. It could be something else going on. So sometimes we do the ERA with those microbiome tests. Sometimes we do them alone. So again, a relatively new area of research. I think it's one that's going to really carry on snowballing. So we need to see how it goes.
Interestingly, when I first started working with people going through IVF, a really popular treatment was the endometrial scratch.
Yes.
But that doesn't seem to happen anymore.
Which is strange, because this is one of them where it works the other way, in that with some like PGTA and ERA, the HFEA have gotten them as red, and we think they're more valuable than they are, or we do it at the Lister. And with the endometrial scratch, it's one that the HFEA have still got as amber, but most people have stopped using it.
Yeah.
There were some studies a year or so ago that suggested it didn't improve the outcome. But again, it's still one that on balance, there is a little bit of evidence for. So they've got it as ERA. It may just be because, as uncomfortable as it can be, it's relatively non-invasive, it's relatively cheap, and it may be that's why they haven't quite tipped the balance to red. Because things like immune testing, they're more expensive, they're more risky with some of the treatments. So the threshold perhaps is slightly different as well.
So say for example, if somebody's going for their first round of IVF,
yes.
and let's say they've got unexplained infertility.
Yes.
So, there's no underlying issue, but they're going through IVF. What kind of conversations in terms of what add-ons at that point would you be having with
Interestingly,
a person?
the only thing, looking at my little list I scribbled down earlier to make sure I didn't miss an add-on, the only thing I would be talking about is the one that's not there. And it's not an add-on, as you said earlier, it's sperm DNA, because, if somebody's sitting there in front of me at 43, we probably know they're not getting pregnant. If somebody's sitting there in front of me at 33 with 2 or 3 years of trying and everything else is okay, the first question is, why aren't they getting pregnant? And it's only worth doing a test if it's going to change what we're going to do. And sperm DNA will. We know that couples with a high level of sperm DNA have got a lower chance of getting pregnant, so it's information. Number 2, if it's high, we should be doing ICSI rather than IVF, possibly with sperm selection techniques like the Zymot or IMSI. And number 3, if it's particularly high, even doing those techniques may not improve the outcome. So we should be getting them to see our urological colleagues to see how how we can decrease it. So I think for me, a youngish couple with unexplained infertility, sperm DNA is absolutely the thing I would do. Beyond that, I would do none of these. I would have a conversation about genetic testing, and just perhaps put that in their mind to have a think about, predominantly not to freeze them all and test them all, but perhaps if they respond really well and they've got some extras to freeze, to test those. So those would be the 2 things that I'll be talking about.
So I guess really, for anybody listening to this, I guess it's to have the conversation with your consultant to discuss what options are available that are relevant to you and your situation, because it's so personal, isn't it? Depending on your age, your history, your partner, if you have a partner, all those things are very sort of individual.
Absolutely. And ask about them all. Hopefully whoever you see will tell you yes, no, what they think about all of them. And as I say, in the scenario you gave me for that patient, most of them you don't need, because they're not going to overcome the problem that you've got at that point. Later on, if we see an issue, we can think about acting on it. But at that point, there's nothing else. But yes, the answer is absolutely a conversation.
Yeah. And so if people want more information, I guess, because the thing is about the HFEA website is it's there are some good stuff in there, but it is also quite confusing and overwhelming. So I guess what we're saying is to have a look, but also speak to your consultant.
Yeah, I think that's the key. We've tried to, in the information that we give to everybody, we've given all the information the HFEA give, but tried to do a summary at the end in the Lister opinion. And so I think getting that information from your clinic, because it's important that you get that. Yeah, and also having that conversation, specifically asking the questions that are relevant to you.
Yeah, so is that information on your website? Is that something that you give out to people?
It is on our website, I believe. Our website's about to get a revamp, so if you can't click on it quite yet, apologies. But it's on, we give it as part of the initial info we send out to every patient.
Yeah, okay. Thank you, James.
That's all right.
That was very, very helpful and very informative, which is what we want this podcast to always be.
Good. It's a pleasure. I hope it was useful for everybody.
Yeah, and I will put links to everything that we discuss on the show notes, so there's more information there if you need it. So thank you once again, James.
It's a pleasure.
We hope you have found this helpful. If you'd like more on fertility education, please see our Teaching to Conceive free course linked at the end of the show. You'll also find the link to join our community. For more personalised fertility support, you can work with us one-to-one in clinic and online. You can book a discovery call to find out more.